Hello, welcome to the biological explanations and treatment support homework that you need to be completing for your next session with me. Really important, if you're not sure of anything, you must watch the YouTube video in full. You must read The Green Haired Girl, which is attached to the email I've sent you, as well as the cat book. Do some research on the internet, look at Tutor to You, and finally, and most importantly, if you're still not sure, before session, you must speak to me. This is the last session we're going to do, and on anything new before its revision, and I want to move through things quickly, but I'm absolutely positive that everyone must be really clear on it as well, because obviously we don't want to rush. There's no benefit to rushing if you're not really clear on the information. So we've got the biological explanation of OCD. Don't forget you need to know the emotional, behavioural and cognitive characteristics of OCD if you look back on your match table as well. So we've got two different types of explanation, the genetic explanation and the neural explanation, and they link really nicely together. So the genetic explanation focuses on faulty genes that we have, and two of the faulty genes, one is the COMT gene and one is the SERT gene, and ideally you want to know them in full, but it's not essential. Other things are far more important. So the COMT gene is responsible for the production of dopamine, which is a key neurotransmitter which is involved in OCD, and you need to know about that for your neural explanations. So this is why they link really nicely. But there is a gene responsible for the production of dopamine called the COMT gene. If that gene is faulty, then it's more likely to cause OCD. And as we found, the faulty form of this gene is regularly found in a lot of people with OCD, although not all of them. And then this variation, so this fault in the COMT gene, means that there is lower or a decreasing of dopamine. So if we just have a look at that again, the variation means that the COMT, so the fault in the COMT gene, means that COMT activity is lowered, therefore increasing the levels of dopamine. So the fault in the COMT gene means that the COMT activity is lowered, and dopamine, because of that, is increased. There's also the SERT gene, which is linked to serotonin, so the S for SERT and the S for serotonin, and it's to do with a serotonin transporter. And it affects the transportation of serotonin. Basically, it means that there are reduced levels of serotonin. And again, they found that 6 out of 7 family members with this faulty SERT gene had symptoms of OCD. And then there's the diathesis stress model we'll go through more in class, but it's the idea that the gene gives us the vulnerability to OCD, but actually it's far more complicated than that, because then they also need environmental stresses. So just because you have the vulnerability to OCD, if you have a really nice life that doesn't kind of have any stresses involved in it, then you're less likely, then you could still not develop OCD. However, the key kind of what we'd call the sweet spot, the bit in the middle, would be you have a vulnerability for OCD, and you also experience some stresses, which then lead to its development. And also in the same way, it could be that you don't have the genetic vulnerability, but you have an increased number of stresses, which also causes OCD, and we can apply that to lots and lots of different things, and that's the idea of the bucket analogy. So if we're born with a vulnerability to OCD, our bucket's born half full, and then stresses add to the water in the bucket until eventually it overflows. But we'll look at that more closely in class. I'd really encourage you to be aware of that one. Okay, so there are the genetic reasons, they're the genetic things, and then we look at the neural explanations, and the key one is the abnormal levels of neurotransmitter, which of course links back to the genes. So we've got high levels of dopamine in those with OCD, and that could be due to a fault in the COMT gene, which we've looked at, so the activity in the COMT gene is reduced, increasing dopamine. And there was a piece of research that found increased dopamine levels in animals created repetitive movements similar to those with OCD. So those same obsessive behaviours in OCD were seen in animals when animals' levels of dopamine increased. So we can be fairly confident of cause and effect there, apart from obviously the issues with animals, which we'll look at in extrapolation. We then have lower levels of serotonin, and again these low levels of serotonin are due to issues with the fault within the SERT gene. And increasing serotonin through the use of antidepressants, which focus on serotonin, decreases OCD symptoms. So the idea that serotonin is increased levels of serotonin reduces OCD. So there are depressants that increase levels of serotonin, there are antidepressants that don't increase levels of serotonin, and the antidepressants that increase levels of serotonin have been found effective to reduce OCD symptoms. The antidepressants that do not focus on increasing serotonin do not reduce OCD symptoms, suggesting that low levels of serotonin are a cause of OCD, because increasing levels of serotonin removes OCD. Okay, and there it says antidepressants that do not target serotonin do not reduce OCD symptoms. Okay, so that's the neural explanation. And then we have the more complex brain circuitry. So someone without OCD, the occipital frontal cortex sends warning signals to the thalamus about things to worry about. So if it's not a normal person, someone without OCD, then the OFC would send signals to the thalamus that are things that are sensible to worry about. So you should probably worry about the exam that's coming up, you need to revise, you should probably worry about that big tiger that's going to eat you, you should probably run away from it, and so on. The caudate nucleus, or however you pronounce it, it's vital that you spell it correctly, suppresses signals from the OFC which are not needed to be worried about or not important. So it doesn't really sort of those things that perhaps don't necessarily make so much sense. So it's not vital to be constantly worrying about germs if you're in a fairly clean and fairly healthy environment. So in someone without OCD, the OFC sends signals to the thalamus to warn them about things to worry about. However, the caudate nucleus kind of goes, nope, that's not something that needs to be worried about. So it suppresses the signal from the OFC for things that are inappropriate and unnecessary to be worried about. Someone with OCD, that nucleus is damaged, so worry signals from the OSC are sent to the thalamus about everything, so that you can worry about a variety of different things. And this would, of course, explain patients with OCD's obsessive thoughts, the fact they can't stop worrying and thinking about things, because the nucleus, which usually stops worry signals from the OFC to the thalamus, isn't working, so the OFC is constantly sending worry signals to the thalamus. Okay. And this is supported by brain scans that show heightened activity in the occipital frontal cortex of OCD patients, especially when they're experiencing obsessive thoughts. So those obsessive thoughts in anybody else those worries might be caught and stopped by the nucleus, but in OCD patients they're not. Okay, and then we've got the link with serotonin and dopamine. So serotonin is a link to the function of OSC. So serotonin levels in people with OCD is abnormally low. So serotonin is involved in the regulation and the functioning of the occipital frontal cortex, and as we know, serotonin levels are abnormal in people with OCD, and therefore that might explain why the additional worry signals are sent. And also dopamine is linked to the frontal lobe, where the OFC everything we've looked at, the nucleus, the OFC, the thalamus, are all stored, and high levels can lead to overactivity in this brain, so that part of the brain is constantly overworking because of the amount of dopamine. So worry signals are getting sent to the thalamus more often, and the nucleus if it's damaged, isn't working effectively to control those signals. Now that's the most complex part of it, so if you're not sure about that, don't worry as much, although it's really useful to be aware of. The other ones, the key ones to understand, are the COMT gene, the SIRT gene, ideally diathesis stress model, and of course the abnormal levels of serotonin and dopamine. Okay. And then the treatments. So you all know about neurotransmission, the idea that the electronic impulse runs down the axon, and I will be testing you on this in class, so make sure you revise. The electronic impulse runs down the axon of the presynaptic neuron, triggers the vesicles in the presynaptic neuron, they move to the edge of the presynaptic neuron and release neurotransmitters into the synaptic gap. The neurotransmitters go across the synaptic gap and they bind to the receptors on the postsynaptic neuron, and then depending on whether they're excitatory or inhibitory, they make the postsynaptic neuron more or less likely to fire. They're then pushed back into the synaptic gap and reabsorbed through a process called reuptake back into the vesicles, ready for it to happen all over again. Somebody with OCD has low levels of serotonin, so there's not enough serotonin in the synaptic gap. So SSRIs block those transporters, and you can see on the image here there's a transporter blocking them, so they cannot be reabsorbed. The process of reuptake cannot happen. So there's more serotonin floating around in the synaptic gap, so there's more opportunity for it to bind to the receptors, and it says there on the bullet point. So it blocks the reuptake of serotonin, more serotonin in the synaptic gap, increases the amount of serotonin binding to the receptors, so reducing the levels of activity in the worry circuits. As we saw, serotonin was linked directly to the worry circuit, and low levels of serotonin cause problems. So if we increased it, then worry circuit would function correctly. If you're completely lost by all of that, then there is the YouTube link below, which really breaks it down, which is extremely useful and I can't encourage enough. So revise synaptic transmission in general, and then revise SSRIs. It's dead easy. If you know about synaptic transmission, all you need to know is the SSRIs block the reuptake of serotonin in the transporters, which means there's more serotonin in the synaptic gap, which means that more serotonin can bind to the receptors in the postsynaptic neuron and do the work, whatever they're supposed to do, be it excitatory and inhibitory, because of course neurotransmitters can be either, although generally serotonin is viewed to be inhibitory, but of course not always, so don't talk about that. Okay, and then there are types of SSRIs, so there's some names, and then of course the tricyclics. So tricyclics focus on both serotonin and neurotransmitter, neuroadrenaline as well, so you can talk about both of those. If you've got any questions, please let me know. Do email me before session. Other than that, good luck.